30% together with the Alzheimer, and there will be the most important causes of mortality. In the right panel, we can see the predicted growth of the top 8 causes of death in Spain, based in our registry. Based in our registry, we can see that also in 40-30 years, Alzheimer and chronic kidney disease will be the main causes. And if this is the changes among main causes of death in the world. So chronic kidney disease has been in the 16th place, and in 2040 will access to the first part. So the chronic kidney disease will causes of death in the world. On what happened of the incidence of end-stage renal disease? This is the registry of United States, the last data of registry. Despite of all of this, the incidence is increasing, and diabetes is diabetes is one of the main comorbidities on this patient, affecting 60% comorbidity, about 50% of etiologies. And even it continues increasing the patient with diabetes, because diabetes is the main cause of end-stage renal disease in this patient. So the next slide, all of you know this slide, because type 2 diabetes is a growing problem affecting 30-40% of the 400 million diabetes patients in the world. But this more important than seeing here is a map of the diabetes burden around the world, according to the latest edition of International Diabetes Federation Atlas. And it's important to point out that the Western Pacific and South Asia region contains the largest population of people with diabetes. You have to take into account that approximately 1 in 3 people with diabetes will eventually develop chronic kidney disease. So, talking about chronic kidney disease definition, all of you know that the KDIGO guidelines defining chronic kidney disease of abnormalities of kidney structure or function presented more than 3 months, with implication for health. So there are 2 parts. One, markers of damage, albuminuria, urine sediment abnormalities, electrolyte alteration, abnormality in histology of bioimaging, or history of kidney transplantation, and decreased GFR. All of you know that decreased GFR is a chronic kidney disease, but it's important to transmit to the other specialties that it's important that nephrologists convey to other specialties that definition of chronic kidney disease not only includes GFR, but also includes albuminuria as important risk factor. If we don't measure albuminuria, we won't be able to adequately stratify the patient. If you don't search, you won't find. And the patients with preserved GFR may have a high cardiovascular or renal risk in the presence of albumin, albuminuria, or proteinuria. This is important to convey to other specialties, especially for GPs, because the GP are the face of the medicine, and all of them have to give us, help us to keep the patient, to prevent the chronic kidney disease. And chronic kidney disease is defined as abnormality of this story for 3 months, and now in the last KDIGO guidelines, CKD is classified based on 3 points: cause, GFR category, and albuminuria category, with the abbreviated CGA. So what's the definition of diabetic nephropathy? This concept of diabetic nephropathy has changed in the last years. Diabetic nephropathy classically is renal involvement as consequence of diabetes mellitus, characterized with established albuminuria greater than 300. This is the proteinuria, with a progression of the nephropathy that progresses to end-stage renal disease. But the concept, this is more heterogeneous, because the current concept is kidney function can be lost in absence of albuminuria, and diabetic nephropathy has changed to diabetic kidney disease, and currently the guidelines say you should use the chronic kidney diabetes of diabetes mellitus. This is the current concept. So why? Why? Because there are some points to take into account: the natural history of kidney involvement, differs between type 2 diabetes and type 1 diabetes. A significant percentage of patients with reduced GFR don't present increased albuminuria excretion, and the existence of kidney damage in diabetic with predominance of tubular interstitial vascular involvement rather than glomerular involvement typical for the diabetes. So the concept of diabetic nephropathy has evolved into a more heterogeneous and modern concept, and this is due because a series of circumstances that present the chronic relation in patients with diabetes. Those patients can present hypertensive nephrosclerosis, multiple toxins, or ischemic, and so on. So currently, diabetic nephropathy is only considered when we have a report of histological changes. So we have to comment diabetic nephropathy, histological pattern, and the rest of concept as chronic kidney disease of type 2 diabetes. This is the current concept. So what's important for considering renal progression and cardiovascular risk in type 2 diabetes together? This is data, all of you know this data about UKPDS study. This is on the left panel. This is the annual transition rate in the different stages of nephropathy and mortality for any cause. So this is the transition rates, the annual risk of mortality, of risk of death. This is the 2% to 3% of transition rates. But when the patients have micro and macroalbuminuria, the annual risk of death is increased. So in patients with end-stage renal disease, this is nearly 20% of the patient death, this high rate of mortality. So among this patient with UKPDS study who presented elevated creatinine at the beginning of the study, at 10 years, only 8.5% were alive. The mortality is really high on this patient. On the other hand, of the right panel, chronic kidney disease is associated with high cardiovascular mortality and represents the presence of chronic kidney disease or diabetic kidney disease and high mortality, cardiovascular mortality with an excess of mortality, especially those patients with albuminuria and impaired GFR. So it is important to prevent not only the progression of the nephropathy, but also the prevention in cardiovascular mortality. And this is confirmed in this study because this study included more than 1,000 patients with GFR below 60, followed up after the event of end-stage renal disease and non-cardiovascular death or any other event. And in this case, all the adults have 3-fold more likely to die from any cause that progress to end-stage renal disease. And in case of cardiovascular death, those patients with GFR below 60 has 6-fold more likely to die from cardiovascular causes to develop end-stage renal disease. So it's more important to treat the cardiovascular condition of this patient than the progression. Of course, we have to try the progression of diabetic kidney disease, but we have to choose drugs that improve not only the renal progression, that improve the cardiovascular mortality. So chronic kidney disease in type 2 diabetes is the main cause of renal replacement therapy in the world. 28% of diabetics have some degree of nephropathy. 1/4 of type 2 diabetes has albuminuria at 10 years of the diagnosis. And in general, 40% of those patients will present nephropathy during its evolution. So we should add in earlier stages, and this is especially the message, especially for GPs, because they have the key for the prevention of chronic kidney disease in type 2 diabetes. Early prevention and treatment for cardiovascular morbidity and mortality and renal progression. So what is the prevalence? We're talking about what percentage. So this is the prevalence of different studies, for instance, a Spanish study or an Australian study. In general, 1 in 4 patients has GFR below 60, 25. For 13%, 30%, 10% are the patients that have microalbuminuria. A less number with 3% patients have proteinuria. So, and those patients with low GFR and albuminuria are about 25%. Even in Australia, 47%. There is an overlap of the microalbuminuria at year below 60. So this is an important problem in those patients. The NANES study in the United States informed that in the number of patients. Sorry, may you mute the microphone? Thank you very much. And this is number of patients with diabetes with any kind of chronic kidney disease, 20%, albuminuria 6%, proteinuria 46%, and GFR below 60, 12%, and below 50%. So in this table, show the data in diabetic and non-diabetes patients. It's clearly observed that patients with diabetes mellitus, in those patients, the prevalence of albuminuria and proteinuria and the GFR.
Prof. Mutwalli, sorry, Prof. Mutwalli, could you mute your mic? Yeah, go ahead, continue.
Okay, thank you very much. So the next point is, how does kidney involvement occur in type 2 diabetes mellitus? So this is a point in that express in the diabetic milieu, the metabolic ranges and hemodynamic alteration, particularly activation of renal angiotensin system, trigger different signaling cascades, including protein kinase C and Janus kinase, that through this activation transcript some factors as NF-kappa beta, because nephrology we know perfectly this is a relevant point for the lesions in diabetic kidney disease. So in response to the such signals, renal tubular epithelial cells, podocytes, and mesangial cells can produce chemokines, growth factors, fibrotic cytokines that promoting macrophages, and this is less at the end of inflammation and progressive fibrosis and low glomerular filtration rate. So at this point, in this image, we can see the process when it affects with glomerular basal membrane in an environment with high glucose or angiotensin 2, hypertensive and high-risk patient. A number of inflammation mediators are produced, and you can imagine this is a battle. This is a battle when there are several players in the battle, and they are insulin growth factors, TNF alpha beta, vascular endothelial growth factors. As a result of this battle, the glomerular barrier is damaged, resulting in albuminuria, and the patient is the victim. We can measure the albuminuria because it comes from out of the urine, whereas it's not possible previously, but obviously this leads to albuminuria. And when will proteinuria appear? So in physical condition, under physical condition, high molecular weight proteins do not pass the glomerular basal membrane, and a small part of albumin passes, but is reabsorbed by the tubule because its capacity is enough to reabsorb a small amount of albuminuria. But when there is an alteration in the permeability of glomerular basal membrane, a patient of low molecular weight proteins, albuminuria, and a greater extent of small amount of proteins occurs. So on the right part, but we also have to consider proteinuria, because this passage of low molecular proteins, albuminuria, leads to a high degree of proteinuria. So, but we also have to consider the tubular proteinuria, because the tubular proteinuria produces lesion in the interstitial area, because there are glomerular area and interstitial area, and tubular proteinuria results when glomerular function is normal, but the proximal tubules are diminished the absorption capacity. The tubules absorb a small amount of albuminuria, but when the patient has high degree of albuminuria, the tubules they won't be able to absorb all the albuminuria, and the proteinuria passes to the interstitium, and this proteinuria in the interstitium activates the production of anti-inflammatory mediators. So this is these anti-inflammatory mediators produce interstitial fibrosis. So we can detect also tubular proteins, and they lead to renal failure, interstitial inflammation, renal fibrosis. Okay, And this is the part after this damage of glomerular basal membrane, you are able to detect the albuminuria in albumin creatinine ratio measurement. Okay, and how does chronic kidney disease progress to end-stage renal disease? This is important, the participation of interstitial fibrosis. The interstitial fibrosis is also important in the progression of chronic kidney disease. So this proteinuria led to cytokine inflammatory chemokines. At the end, this inflammation leads to tubular fibrosis. The tubular fibrosis in a protein accumulation activates the cytokines, growth factors, interstitial inflammation, and interstitial fibrosis, and leads to a small kidney with chronic kidney disease, glomerular scarring, and glomerular fibrosis, and interstitial fibrosis, and tubular atrophy. So this leads to a decrease on glomerular filtration rate, a decrease of surface of glomerular filtration, and interstitial fibrosis. And what are the risk factors for renal progression? These factors is the non-modifiable factors. We can do much for these factors, but we should at least take into account, because some of them have factors for susceptibility, initiation, or progression. So we have to consider when we have a black man and patient with reduced mass, low birth weight, and even low socioeconomical levels. So these are the modifiable risk factors, systemic risk factors, that in these factors are the factors on which we can act to prevent the progression of chronic kidney disease. If the patient has diabetes, we should control optimally. If the patient has obesity, we should avoid obesity. We should control optimally the blood pressure. We should avoid kidney injuries, as acute kidney injury, toxin, nephrotoxic drugs, non-steroidal anti-inflammatory drugs, to avoid tobacco, to avoid to prevent or avoid or treat urological problems such as infection or obstruction, and avoid to high protein intake. All of this may be related to initiation or progression of renal disease. So a couple of slides about monitoring, because the second speaker will deal this in depth. I only want to spread that the different guidelines recommend the measurement of estimated GFR and urinary albumin creatinine ratio for the detection and monitoring of CKD. And sorry, yes. Okay, sorry, there is a problem? No. Okay, and this is the guidelines recommend. Sorry, just a minute, please. It's a technical problem. Yes, what's the problem? Sorry, what's the problem?
Grace, what's the problem? Who's
Try to resolve that? It's a problem because it appears yes, okay. It appears on logos behind me, because this is for previous meeting. I suppose it was for you, because just a minute I had to okay, to camera, sorry. Okay, okay,
just go ahead. Yeah, go ahead.
Okay, yes, because it was the previous meeting 1 month ago, because I don't use
make it full screen, please.
Okay, yes, sir. Okay, all right, it's okay.
Yes, carry on.
Yeah, okay, because my apologize, because this is for the previous Congress, the Spanish Society of Technology.
Just go, no worry, go ahead, carry on.
My apologies. So, talking about the guidelines, talk about the type 1 diabetes mellitus should be used with microalbuminuria yearly after starting 5-year diagnosis, and type 2 diabetes every year. So I don't want to stand with this, because the second speaker will be with this. And the important is that screening for CKD in type 2 diabetes it should be at least annually for urinary albumin. And most doctors forget about to perform this albuminuria. Most of them perform GFR, but they forgot about albuminuria. So American Diabetes Association and KDIGO recommend at least annually, and even in those patients with proteinuria or of and GFR low GFR, the number of determinations should increase. Even if you are treating with drugs that can modify the albuminuria, the guidelines recommend to perform a screening at least twice a year. Okay, and the last point I would like to deal with this problem is that chronic kidney disease underdiagnosis in type 2 diabetes. This is a study, a multi-center study in the United States, in GPs, and they tried to analyze the clinical survey, physical examination, hemoglobin, GFR, and albuminuria, and several records from the history, and they detected that in earlier stages, only 88% of the patients in general are diagnosed for CKD, but the 85% of the patients have GFR, estimated GFR measurement, 50 mils per the admission, but only half of the patients have albuminuria measurement, especially in the early stages. Every patient older than 60 years, every patient with hypertension, every patient with risk factors should include the albuminuria together with estimated GFR in the measurement, okay, for detect chronic kidney disease. So next point I would like to address is when to consider other nephropathy in patients with type 2 diabetes. So this is important because given the high prevalence of type 2 diabetes in the general population, 12, 14%, 50%, a variety of forms of chronic kidney disease in diabetes can be seen, including diabetic nephropathy, ischemic nephropathy, and related to vascular disease, hypertensive nephrosclerosis, and all the points. For example, this is an overlap of a lot of causes with hypertension, ischemic nephropathy, and this happens in patients with diabetes or without diabetes. So how can we distinguish, because there are some overlap in most cases? This slide shows some concerning clinical and laboratory features that would lead to suspicion of a kidney disease unrelated or related to diabetes and require additional testing or referral for nephrology and potentially a kidney biopsy. For example, we have a patient, when I meet very often with GPs of my department, I tell, if you have a patient with slow and progressive albuminuria and blunt urinary sediment, no hematuria, no leukocytes, no red blood cells, a slow progression of diseases, and other complications of diabetic retinopathy, and diabetic neuropathy, diabetic food diabetic, so and so, and known duration of diabetes greater than 5 years, probably these patients have diabetic nephropathy as a renal disease. But if we detect some of these factors in the right side, for example, they are rapidly increasing proteinuria or extreme proteinuria, this is not a clue for thinking about diabetic nephropathy of main cause, or the presence of an active urinary sediment, persistent hematuria. This is a glomerulonephritis or urologic causes. A low or rapid decrease in GFR, and low GFR with little or no proteinuria, and other causes for 50% reduction of GFR after ACE inhibitors, and family history of non-diabetic kidney disease. So this data are suggesting a non-diabetic kidney disease and should refer to a nephrologist to further studies. And the last point, the next point is to referral criteria to nephrology. Several guidelines talk about the referral, when to refer the patient to nephrology. The importance is to work together, primary care, other specialists, and nephrologists. And this is the risk of progression and frequency of visits and referral from nephrology according to KDIGO guidelines. The number of visits, the number of visits are marked in its area, and in red are the patients with high risk. In general, patients with albuminuria greater than 300, proteinuria, this in general, they should refer to nephrologist because they are more rapid progression, and we say to take all the actions. And general GFR below 30, you should refer. And those patients, this is a discussion, but those patients with mild albuminuria and mild low urea, especially young men, should be referred to the nephrologist. So in general, our guideline or national guideline from Spain, KDIGO, and NICE for UK, the number is 30-300, 30 GFR below 30 and albuminuria greater than 300. This is the two key for referral to the nephrology. But in general, you should refer albuminuria greater than 300 unless that you know the albuminuria to be caused by diabetes and is appropriately treated and non-progressive. A 5-year risk of needing renal replacement therapy using the kidney failure risk equation, a sustained decrease on GFR, more than 25% per year, or 15 milliliters per minute more than 1 year, and no suspected other genetic causes of kidney disease, renal stenosis, or potassium disturbances. In general terms, patients with albuminuria greater than 300, albuminuria in any degree of accompanying glomerular microhematuria, non-urologic microhematuria, this is probably a glomerulonephritis, and those patients with GFR below 30, that except with very old patient without renal progression or without irrelevant albuminuria and without alarm signs such as macroalbuminuria, and no planned renal replacement therapy. So, okay, this is the guidelines, but if we use the guidelines, we should refer this patient too late because GFR below 30 and proteinuria. This is a proposed intervention that we published recently in chronic kidney disease. The proposed intervention, the early intervention, and this is made by GPs. GPs have the clue, GPs have in their hands the possibility to prevent the progression of renal chronic kidney disease. Because if we add in patients with very low GFR, we can do anything. Our strategies are very few effective. The strategy more effective is as early the treatment, the better the prognosis to prevent the chronic kidney disease. So on the next point, the last point of my talk is talk about the renal endpoints used in the clinical trials in chronic kidney disease and diabetic kidney disease. Because in most clinical trials, we are seeing doubling serum creatinine, renal death. What does it mean? I tried to summarize. This is a paper published some years ago explaining all the renal endpoints using these clinical trials. Is in the paper is very specific explaining. We can access with this Q code. So first, what's doubling serum creatinine? Very often used. Doubling serum creatinine is the first value used of serum creatinine detected that is twice the value determined at the beginning of the study, of the baseline. So I have 1 milligram per deciliter of creatinine, and the patient passed 2 milligrams during the follow-up of the study. It's usually evaluated at least after 4-6 weeks because you should repeat. Most of these patients at your clinics have presents changes in GFR, but in most cases are functional changes due to diuretic treatment, non-steroidal anti-inflammatory drug. And when we are analyzing these clinical trials, this doubling serum creatinine should be repeated to confirm. This corresponds a 57% reduction in GFR, but this is hard endpoint. We need a lot of time to detect 57% reduction in GFR. So that's why we use doubling serum creatinine or plus confirming sustained 40% decrease in GFR. This is the endpoint in MPAREG. Always you should confirm it. So others need for renal replacement therapy. This is very clear. The patient needs end-stage renal disease, they need dialysis. But in some studies, this need for renal replacement, because we need a long time. We need a long time for this renal replacement therapy endpoint, and it's used together with achieve GFR below 10 or GFR below 15. For example, the credence on DAPA CKD, if the patient reach 15 milliliters per minute, this is an endpoint. Or EMPA-KIDNey, 10 milliliters per minute with GFR below 50 at baseline, as such DAPA heart failure. And the next point is renal death. It's a very controversial term. Renal death is a death due to end-stage renal disease when dialysis treatment was deliberately withheld. The patient needs dialysis, but we decided, the family of doctors, they decided not to perform dialysis for any reason, futility, or the family rejection to dialysis treatment. This happens sometimes. This is less than 1% in the clinical trials, 0.2, 0.5%. But some patients, especially diabetic patient, has a stroke and as complicated, but the patient need dialysis because of high uremia or severe hyperkalemia or other conditions, and the family decided this patient has a stroke as no movement. We decided for futility not to do anything to the patient. This is renal death. This renal may be avoided by dialysis, but the condition the patient has to illness, the sickness is too ill, and the patient or the family or the doctors decided not to perform dialysis. This is renal death. Other term is onset of worsening nephropathy. This is in some studies, a progression to macroalbuminuria. It should be confirmed at 4 weeks, or doubling serum creatinine plus GFR below 45 is other term of worsening of nephropathy, or the start on replacement therapy or renal death. This is a combined endpoint that has been used in several trials, such as SUSTAIN, for example, LEADER for GLP-1 receptor agonist. The next point is onset of albuminuria in patients with normal albuminuria. The patient developed albuminuria greater than 30 milligrams per gram and requires confirmation. And the next point is sustained improvement in albuminuria. This is a new point. 20 years ago, we can't believe that albuminuria can regress. With the inclusion of new drugs, especially for SGLT2 inhibitors, more of our patients normalize the albuminuria. It is a sustained improvement of albuminuria, and this is including clinical trials. But the problem is that in each study, the investigator has used different renal endpoints, contrary to what the cardiologists do. The cardiologist is very pragmatic, and MACE, the MACE is very clear, and they use on the same measuring stick, and we're using in EMPA-REG, doubling serum creatinine, in CANVAS, GFR below 40, in credence, doubling serum creatinine, in DECLARE, doubling serum creatinine below 60, and DAPA CKD 50. My God, such a nightmare. We should need an agreement, and this agreement is MER. This author, the Dr. Banner and Dr. Prisel, proposed that develop and define serious renal adverse event and major adverse renal event comparable to 10 MACE. MACE corresponding to serious cardiovascular adverse event. MER include a range of serious morbidities such as developing new onset of end-stage renal disease, reaching end-stage kidney disease, or receiving a kidney transplant, mortality. So it's
then Professor Gorez, if you can finish so we can have some time for the clinical, for the second.
Yes. Okay, it was my last slide. And so I want to end my talk employing that will define MAR as the primary endpoint in pharmacological studies in chronic kidney disease that may generate more comparable study results that could make meta-analysis a possible result that help to the nephrologist to establish the prognosis of a patient. Thank you very much for that.
Thank you, Professor Grace. And I think just I have one question, and then we will go to the second presentation. So we know the natural history of DM type of CKD, but I will try to rephrase it. So which one is worse, the non-albuminuric DM nephropathy or the one with, albuminuria?
Yes, in general, the patients with albuminuria progress more. I was very worried about my patient with proteinuria, high degree of proteinuria. But at the start of my talk, I start because we don't know exactly why some patients without albuminuria or low degree albuminuria, they also progress. I was very worried about my patient with albuminuria and tried to decrease the albuminuria. The less albuminuria, the better. But sometimes some patients progress without albuminuria, and we have strategies to treat both patients with or without albuminuria. But in my case, I was very worried about my patient with albuminuria or high degree of albuminuria.
Thank you, Professor Grace. And I think if you can stay with us, till the end of the presentation, so we may get more questions. So we can go to the second speaker for tonight, Dr. Muthanna.
Yeah, it is. You can introduce him. It is recorded talk while also he's with us. You can introduce him.
Okay. So it's my pleasure to introduce the second speaker for tonight's webinar, Dr. Muthanna Sahlawi. Muthanna Sahlawi, he's a consultant nephrologist and assistant professor of medicine and nephrology in King Faisal University, the university that I graduated and Professor Al-Hassan from. So he will talk to us tonight about a diagnostic tool and biomarker for CKD.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. It's really a pleasure to be with you today in this online webinar. I would like to thank you all for attending and, of course, to thank the organizer and the sponsor of this event. The CKD integrated program is actually a very important program that aims to increase the awareness about CKD and the importance of early detection and diagnosis. This program is actually not only directed toward nephrologists, but also to primary care physicians who are the frontliners who play a major role in identifying this disease early. The key in CKD management is the early detection, as early detection can help in implement different intervention that can help in slowing the progression of this disease and, of course, in reducing the associated adverse events. So let us start with the definition of chronic kidney disease. So the KDICO guideline defines CKD as abnormalities in the kidney structure or function that persist for more than 3 months. And this is done by the presence of one or more of the following. So first, glomerular filtration rate of less than 60 ml per minute per 1.73 square meter, or albuminuria as evident by a urine ACR of more than 30 milligram per gram. And lastly, other markers of kidney damage. And those includes, for example, hematuria, abnormal urine sediments, or structural abnormalities in the kidney, such as polycystic or dysplastic kidney. So in order to detect or diagnose CKD, people at risk should be screened with urine albumin measurement and assessment of a glomerular filtration rate. Now, screening is very cost effective in those with a risk factor for CKD, and I'm talking about diabetes and hypertension particularly. Following the testing for urine albumin and GFR measurement, if there are any abnormalities, then it is recommended to repeat those tests to confirm the presence of CKD. Now, GFR can be either measured or estimated. And because measuring GFR is time-consuming and expensive and not always available in all centers, the guidelines recommend to estimate the GFR rather than measuring it. And the estimation can be done by a validated formula, with CKD being the most popular one. So in Estimating GFR, the guidelines suggest to use both cystatin C and creatinine in the formula to estimate GFR. However, because cystatin C is not always available, it is costly sometimes. The guidelines also accept and recommend using creatinine-based GFR estimating formula. However, cystatin C can be sometimes more accurate, especially in situations that can affect the creatinine or lead to misestimation of the GFR, such as in patients with severe malnutrition or severe liver disease, or in those with large limb amputation, for example. This is for GFR. In terms of albuminuria, the guidelines recommend using the urine ACR. PCR can be used also, but the preference in the guidelines is for urine ACR. In both situations, the urine sample for those tests has to be an early morning mid-void sample. Following identification of the abnormality, then we go to evaluate the chronicity. As we said, the abnormalities in kidney structure or function has to be there for more than 3 months to say that this is a CKD. And the chronicity can simply be assessed by looking into previous GFR measurements, or by looking at the previous albuminuria on urine examinations. Other features that can help in assessing the chronicity is the kidney ultrasound, which can sometimes show a reduced size kidney, or also a reduction in the cortical thickness. So the algorithm for screening, as suggested by KDICO, is to screen those with risk factors. And we're talking about diabetes, hypertension, cardiovascular disease, history of AKIs, family history of CKD, obesity. Those with risk factor need to be screened by the methods we mentioned, either by estimating GFR or by checking the urine for albuminuria. And if those are present, and if CKD is diagnosed, the next step would be to classify CKD or stage it. And we'll go to this in the next slide. When we diagnose CKD, or when CKD is detected, the next step is to classify it or stage it. And the KDICO suggests to use the CGA classification. C stands for the cause, G for GFR category, and A for level of albuminuria. So the cause can be identified by history, examination, and laboratory testing. Common glomerular causes include diabetes, SLE. Common tubular interstitial causes include systemic infections, nephrotoxic medications, vascular disease such as atherosclerosis or hypertension, and also cystic and congenital diseases like polycystic or Albert syndrome. So C for the cause and G for GFR category, the famous G1 to G5 category. And then the level of albuminuria, A1 or A2 or A3, based on the level of albuminuria by urine ACR. And the importance of classification is to stratify the risk of the patients. As you can see here, the green indicate low risk, yellow moderate risk, orange is high risk, and red is very high risk. And as GFR decline and as albuminuria increase, the level or the risk increase. And this is why we should know the stage, because this will help in the management, also in the prognosis for CKD progression or for the related adverse events, including cardiovascular disease. So I will not spend much time in epidemiology, as my colleague have already gone through that. I just want to point out that the global prevalence of CKD based on a recent analysis in the Lancet, recent systematic review, is around 10 to 14% of worldwide population. And this is reflected to a roughly 800 to 850 million case. And the prevalence of CKD has actually increased in the last 25 years by 29.3%. And this is likely related to the increase in the prevalence of the risk factors like diabetes, hypertension, obesity, and of course, the aging population. And as CKD progress, the healthcare cost increase, posing huge challenges to countries and healthcare systems, and also to the patients and their quality of life. So diabetes by far is the leading cause of CKD, followed by hypertension. But what about Saudi Arabia? Now, over the last 5 to 6 decades, there has been enormous growth in the kingdom gross national income as a result of the advances in oil production and export. This has led to a significant changes in the lifestyle and dietary pattern of the Saudi population. And as a result, this has led to a significant increase in the prevalence of different CKD risk factors, including diabetes, hypertension, sedentary lifestyle, smoking, and obesity. And so there are no data on the prevalence or incidence of CKD in Saudi Arabia, because most of the studies has been a single center or regional. But if we extrapolate from SCOT data, so SCOT is keeping a track of all patients requiring kidney replacement therapy in the kingdom. And if we look at, those are the number of patients on hemodialysis and peritoneal dialysis. And over the last 5 years, there has been 5% increase every year in the number of patients requiring dialysis. So as of 2022, there are around 23,000 of patients on dialysis, in addition to another 8,000 on kidney transplant. And when we talk about CKD, we have to talk about diabetes. Diabetes has been the leading cause of CKD in the kingdom. Also, by looking into SCOT data, around 42% of patients with end-stage kidney disease are on dialysis because of diabetic kidney disease. Diabetes is highly prevalent in the kingdom, and recently the WHO has reported that Saudi Arabia ranks the 2nd highest in the Middle East and the 7th in the world in the rates of diabetes. It is estimated that around 7 million of the population are diabetic and around 2 to 3 million are pre-diabetes. Now, those numbers are not very accurate, but can give an idea about the prevalence of this disease. In 2014, and this is old data, the healthcare budget in Saudi Arabia was 180 billion. And out of that, 15% was dedicated to managing diabetes and its complication like diabetic foot and eye disease. So it's a major healthcare burden. And here, looking for the rates of diabetes over the last few decades, as I said, like if you look late in the 80s or early in the 90s, the rate of diabetes was around 5% of the population having diabetes. But over the last 2 decades, there has been numerous changes in the prevalence of diabetes, increasing substantially to 23 to 25% of the population, meaning that 1 out of 4 or 1 out of 5 of the population are diabetic. And those with diabetes, and these are different studies from different registries around the world, and have shown that approximately half of patients who have diabetes show evidence of CKD, either as albuminuria or as low GFR or as combined. So CKD is highly prevalent in those with diabetes, and even among those who are newly diagnosed with diabetes, around 20% of patients at the time of diagnosis of diabetes type 2 show evidence of CKD, either as albuminuria or as a low GFR. Basically because type 2 diabetes can go unnoticed for months or year, and during that time, patients is building up complications. CKD is also a major risk factor for heart failure, and the risk of heart failure or cardiovascular events increase as the GFR decline, as we can see here. And in the other figure, also the risk increase as the albuminuria increase. And this is this take us back to the classification. The very high risk patients with CKD are those with the lowest GFR and highest albuminuria. Also, it has been well studied that the coexistence of type 2 diabetes and kidney disease is associated with increased mortality. And this very large US population-based study, here we show the population of, here it shows the mortality, the incidence of mortality among those with type 2 diabetes, which increased by 4.1% in those with, which increased to 70.8% in those with albuminuria. Also, 24% increase incidence of mortality in those with type 2 diabetes and low GFR compared to those with type 2 diabetes alone. And when we combine both low GFR and albuminuria, the mortality or the incidence of mortalities goes up by 47% as compared to type 2 diabetes alone. So basically, the pathogenesis of diabetic kidney disease include both metabolic factors and hemodynamic factors, specifically systemic and glomerular hypertension. All those can lead to the activation of different pathways to oxidative stress, dysregulated autophagy, and epigenetic changes, leading to inflammation, fibrosis, and progression of the diabetic kidney disease. Now, hyperglycemia itself, the systemic effect of hyperglycemia include the enhancement of oxidative stress and inflammation, along with the vasoactive system activation. Those can lead to increase in the vascular permeability, the mesangial cell expansion, and cellular hypertrophy, leading to hypertension and hyperfiltration. And this can lead to glomerular sclerosis, which can result in nephron loss and the progression of kidney disease, and also can lead to the loss of filtration barrier integrity, leading to worsening of albuminuria and again progression of kidney disease. The problem with CKD progression is the more progression, the more poor clinical outcomes and significant burden on the healthcare system and on the patient. Delaying disease progression and reducing the risk of mortality are the key goals in the treatment of chronic kidney disease. This is why early identification and early diagnosis of CKD is perhaps the most important element that we can do as physicians in order to implement early intervention to slow this progression and decrease the related adverse events, specifically the cardiovascular events, which has been the leading cause of mortality in this population. So generally, when we manage patients with CKD, the management should be a multidisciplinary team effort and should focus on reducing the risk of cardiovascular disease by managing the diabetes, hypertension, and lipids. Hypertension management is an important factor in slowing the progression of kidney disease, along with the management of diabetes. We should always remember the importance of appropriate drug dosing based on GFR, the avoidance of nephrotoxic, and the management of CKD complication, including anemia, metabolic acidosis, electrolyte, bone abnormality. And also, we should, in every clinic visit, discuss medication adherence, which is, in my opinion, always an underestimated problem. this is a very common question that we face, is what physical activity advice or what exercise advice we should give to the patients. Now, the KDIGO suggests to advise CKD patients to undertake moderate intensity physical activity like jogging, biking, swimming for a cumulative duration of 150 minutes per week. But this should keep in mind the patient's age, cardiovascular and physical tolerance, and frailty as well. In terms of diet, we should always encourage patients to adopt healthy and diverse diet, focusing more on plant-based foods and, of course, with the avoidance of ultra-processed food. Dietitian should be, the dietitian has an important role in the CKD clinics or renal management clinic in talking with the patients about dietary adaptations, including sodium, phosphate, potassium, protein intake. The suggested protein intake by KDIGO is 0.8 gram per kg per day in those with the stage 3 to stage 5. But we should not restrict protein in those who are at risk of malnutrition. In those patients who are at risk of CKD progression, it is recommended to avoid high protein intake, which is more than 1.3 gram per kg per day. Blood pressure control is very crucial and very important in slowing the progression of diabetic kidney disease. KDIGO suggests targeting a systolic of less than 120, but of course, we can go to less intensive blood pressure target in patients who are at risk of a fall, who are frail, who have history of postural hypotension. Because of their proven efficacy in slowing the progression of CKD and in decreasing the cardiovascular morbidity and mortality. It is recommended, of course, to avoid combining both RAS, avoid combining ACE inhibitors or ARBs, and when prescribed, it has to be titrated up to the maximum tolerated dose with creatinine and potassium being checked after 2 or 4 weeks of initiation. If hyperkalemia is there, the guidelines suggest to take measures to reduce serum potassium rather than stopping RAS or ARB. For example, giving diuretics or the novel potassium binders. So this has been the practice for many years. However, now, over the last 10 years, there has been huge changes in the care and the guidelines for the management of patients of diabetic kidney disease. The novel medications, I'm talking about SGLT2 inhibitors and mineralocorticoid receptor antagonists, have re-evolutionized the management of patients with type 2 diabetes. Especially those with established atherosclerosis disease or a diabetic kidney disease. And also now we keep getting new evidence and new trials, and that SGLT2 inhibitors are also now transforming the management of heart failure and CKD, even in the absence of diabetes. So what does the latest KDIGO guidelines says about SGLT2 inhibitors? It is recommended to treat patients with type 2 diabetes and CKD with eGFR of more than 20 with SGLT2 inhibitors, and this is 1A recommendation. Once SGLT2 inhibitor is initiated, it is reasonable to continue even if the eGFR falls below 20 until patients reach dialysis. It is reasonable to withhold SGLT2 inhibitor during time of prolonged fasting, surgery, or critical medical illness. So it is a grade 1A recommendation in those with eGFR more than 20 and diabetes. So the complete mechanism by which SGLT2 inhibitors protect the kidney is actually not well understood, but there are some mechanisms that have been studied. First, of course, the hemodynamic and the neurohormonal effect by nitroresis and blood pressure reduction, restoration of the tubuloglomerular feedback, and of course, by lowering the glomerular hypertension. There is also hematological parameters by increasing hematocrit, increasing EPO, and plasma volume contraction. SGLT2 inhibitors also have role in decreasing renal hypoxia, decreasing mitochondrial dysfunction, and decreasing fibrotic marker. Also, there is the energy substrate by glycemic management, reduction in insulin, and increasing glucagon, and increasing ketogenesis and weight loss. So all those are different pathways or different mechanisms by which SGLT2 inhibitors protect the kidneys. The other new thing in the guideline, in addition to the SGLT2 inhibitors, is the non-steroidal mineralocorticoid receptor antagonist, the finerenone, which is recommended in patients with type 2 diabetes and CKD with eGFR of more than 25. It is an important medication, especially in those who are at high risk of disease progression with persistent albuminuria despite the standard of care. It can be added to RAS or SGLT2 inhibitors for the treatment of type 2 and CKD. So now we see patients on all those medications on RAS, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. Potassium and hyperkalemia can be a limiting factor, and it is suggested to stop finerenone if potassium level is above 5.5. If it is between 4.9 and 5.9 and 5.5, it is suggested to monitor the potassium closely and try to take some intervention that help in reducing the potassium, like diuretics, for example. So in conclusion, chronic kidney disease is highly prevalent, affecting 8 to 16% of the population worldwide, and is a leading cause of death. And the exact prevalence and incidence of CKD is difficult to be known because of the asymptomatic nature of the early stages of CKD. Current management guideline of CKD put a huge focus on the importance of early detection of CKD in order to implement intervention to slow the progression and decrease the cardiovascular mortality. So with the proper management and timely intervention, it is possible to slow or halt the progression of CKD and improve outcomes for patients. In the light of the recent evidence and the clinical trials, SGLT2 inhibitors have demonstrated a significant reduction in cardiovascular and renal adverse endpoints in different range of patients with CKD. And with this, I will conclude. Thank you all, and I would be happy to take any questions.
Thank you, Dr. Muthanna, and I think we have to go to the question. So I have a few questions for the time being. So the first question was, I think, directed to Saudi Arabia about, the prevalence of APOL1 gene mutation in correlation to CKD. If you know any data, a question to Muthanna.
Yes, thank you so much, Dr. Fadel. So the problem with in Saudi Arabia is that there are no nationwide study to estimate or to measure the prevalence and incidence of CKD. Most of the literature about CKD in Saudi Arabia is based on single center or just region-based study. This is why we don't know the exact prevalence and incidence of CKD in Saudi Arabia, but we keep extrapolating from SCOT data, from the dialysis data, and kidney transplant data, and those data keep showing a steady increase in the numbers of patients requiring kidney replacement therapy. Like the number of patients on dialysis are increasing by 5% every year over the last 5 years. But to answer your question, the easy answer is no, we don't know the exact numbers.
I will direct the question to Professor Grace, maybe from the Spanish data about, the genetic, predisposition, if there is any special allele or special gene involved in CKD.
Yes, this is an important question. Important question because sometimes we have a group of families with increased incidence. Sometimes we don't know why some group of diabetic patients develop chronic kidney disease. On other patients, if we even with non-optimally controlled risk factor, they don't develop. So there are some clear investigation in type 1 diabetes, but in type 2, there is a heterogeneity of the data. And so I told my residents, I told my colleagues that you have to ask to all patients, what is your family? My father, my uncle, I have a lot of relatives with type 2 diabetes. This patient should need any special effort, but we don't have any special data about the susceptibilities of the APOL1 in Black men in the United States. But I would like to suggest, with my humility, but it's important to have registry. When I was secretary of the Spanish Society of Nephrology, we went to the government to talk about the importance of the chronic kidney disease, the established plan against this huge problem you have in your country and we have in my country. And we went to the Ministry of Health and told us, how many are talking about which number of patients with a lot of patients? No, tell me exactly what's the number of the patients. So we perform a study, epidemiological study, to establish the real prevalence in chronic kidney disease. So this is the beginning. And I suggest that we have registry for the governments in each region and in all country, because if you measure the incidence of especially the evolution of the problem, the government should take strategies for this huge problem. So it's important to make registered, especially for renal replacement therapy, and to make some other registry for early stages of chronic kidney disease. That's why the government should establish the plan and should realize that the importance of GPs in this project. The GPs has a crucial point to preventing those, and the medical education for GPs and strategies to help the work of GPs, even nurses, or even government's announcement or planification for this. This is very important for this problem.
Great. I have two questions. One question from the Q&A and one question is that I will direct it to Professor Goris from me. So the first question is through the Q&A. I can direct it to Dr. Muthanna about, the CKD and pregnancy, so which group of CKD that you will allow them to, which group of CKD female you will allow them to get pregnant, and what is the impact of pregnancy on the progression of CKD?
Generally, CKD and pregnancy is not a great mix. The prognosis of pregnancy in CKD is very variable, but generally, the lower the GFR and the higher the level of proteinuria, the worse the prognosis of pregnancy. In all the cases, even in the early stages of CKD, it has to be well planned, it has to be followed up early, and there has to be a multidisciplinary team following this pregnancy, because most of the time it is considered as a high risk pregnancy. A team that include an obstetrician and a nephrologist to try to optimize the outcomes of this pregnancy. And if you allow me, Dr. Fadel, I just want to echo the point raised by the professor. The primary care physicians in the country play a major role in the early detection of CKD. And the hallmark or the key in improving the outcomes of CKD is by detecting it early in order to implement all the intervention and also to slow the progression and reduce the cardiovascular risk, the cardiovascular events, because they are the leading cause of mortality. And it is likely that patients with CKD will die from cardiovascular events than progressing to the dialysis requirement. So finding those patients early is the key, and this is why here comes the importance of like nationwide protocols in family physicians or primary care clinics to diagnose and detect CKD early.
I think it is coming. I think it's coming, and I'm so optimistic, in that regard, and especially with our new graduate from the Saudi Board for Family Physicians. So hopefully we'll see the result in the future. So my question to Professor Goris, since he talked about, the kidney outcomes in patient with CKD. So why we don't see, a protocol biopsy, as an outcome, for all the intervention, especially with the new medication? The question to you, Professor Goris.
Yes, it's, you're talking about in diabetic patients, no? Diabetic patients. Okay. Yes, this is a tricky question because sometimes in my department, we discuss about to kidney biopsy of diabetic patient or not, because I show a list of cues that can help to establish a diagnosis. And in most cases, we prefer to perform a kidney biopsy, but about 20% of our kidney biopsies, and we have a registry in Spain with more than 2,000 biopsies. In more than 20% of kidney biopsy in diabetes, the only finding is diabetes, 20%. But sometimes you have a proteinuria greater than 3-4 grams without even a mild low albumin in level. But sometimes we prefer to perform a kidney biopsy because there are other problems, fibrillary glomerulonephritis and other complexes renal findings. So we decide only perform kidney biopsy in patients with microhematuria, with this list, low GFR, rapid decrease, high proteinuria. And sometimes, in case of doubt, we perform a kidney biopsy. Why? Because there are protocols for kidney biopsy. The kind of biopsy is guided for echography, and the complications are really nearly zero. So sometimes I prefer, and we use electronic microscopy from those patients. We prefer to perform a kidney biopsy more, even knowing that 20% of the patients have only diabetes. But it's very difficult to answer this question.
Thank you, Professor Goris. I'm trying to find a question. I think we have no question. I think just I will leave you with the conclusion by Professor Al-Hassan Abu Abdulaziz.
So thank you very much, Dr. Fadel, for excellent moderating this session tonight. And I would like, once again, thanks Professor Goris, and looking forward to have him face-to-face next time. And also I would like to thank our friend Dr. Sahlawi for really very terrific talk, actually. And I will not forget again to thank our sponsor company, Boringers. Without their supports, this education wouldn't happen. So we'd like to thank them of being supporting this talk. So the last thing, just I would like to mention that the CME hours will be earned automatically to the accounts of those who registered and attended the talk. Would like to apologize. We make it 1,000 because this is the regulation came from the Saudi Council that maximum will earn CME hours for webinar is 1,000 attendee. So thank you very much. See you inshallah next time with another educational events, and have a good night. مع السلامة للجميع.
Okay, thank you everybody, and have a nice and good night everybody. Thank you.
Good night. Thank you very much.
يعطيكم العافية جميعا وفي أمان الله.